Welcome to today's webinar. My name is Debbie Hoyer, and I'm a public health advisor in the Office of Disease Prevention and Health Promotion, or ODPHP. ODPHP is within the U.S. Department of Health and Human Services and manages the Healthy People Initiative. Over the next hour, you'll learn about 3 Healthy People featured objectives and how they relate to diabetes prevention, treatment, and management. Next slide, please. Before we begin, a quick note that the speakers and moderators for today's webinar do not have any commercial relationships or conflicts of interest relative to today's educational activity to disclose. Next slide, please. We are pleased to announce that those attending the live webinar today can submit for select continuing education hours. Those are listed on the slide. Next slide, please. Following the webinar, participants will receive an email from cpd@confex.com. That email is listed on the slide with instructions on how to obtain continuing educated credit and a certificate. Now, let's focus on today's webinar. Next slide, please. Each quarter, ODPHP hosts webinars to connect the public with information and resources related to Healthy People 2030 objectives, giving organizations in state, tribal, and local governments tools to improve health and well-being. In addition to reviewing the latest data on select Healthy People 2030 objectives, these webinars feature states, communities, or organizations working to achieve the Healthy People 2030 targets, acting on these important public health topics. You can join our Healthy People listserv to receive real-time updates on the dates and themes of upcoming webinars. Next slide. Today's webinar is titled Healthy People 2030, Empowering Diabetes Prevention, Treatment, and Management. And we're excited to be offering a slightly different format today for our webinar. For those who've attended previous webinars, you may remember that our webinars feature a presentation from one organization that works in the field addressing the featured theme. Today, we will hear from 2 organizations, and the representatives will engage in a structured conversation covering today's topic. During our post-event evaluation, you can let us know what you think about the format. With that aside, let me introduce today's speakers. We'll first hear from Rear Admiral Paul Reed, Director of the Office of Disease Prevention and Health Promotion, on the importance of the Healthy People 2030 objectives featured today. Following Rear Admiral Reed's presentation, we'll hear from Commander David Huang, who is the Branch Chief of the National Center for Health Statistics, Health Promotion Statistics Branch. Dr. Huang will provide details on current progress toward meeting objective targets for the 3 featured Healthy People 2030 objectives. He'll review differences observed across population groups and provide some key data takeaways. Lastly, we'll hear from Dr. Kevin Peterson and Paulina Duker. They'll discuss how the objectives featured today support high-quality diabetes care delivery. Dr. Peterson represents the American Diabetes Association, which funds diabetes research, drives recommendations on diabetes standards of care, and promotes resources and policies related to food and nutrition. Paulina Duker represents the Association of Diabetes Care and Education Specialists, which is an interdisciplinary professional membership organization dedicated to advancing the quality of diabetes care and education. These organizations are part of the Diabetes Advocacy Alliance, or DAA. The DAA is a coalition of 25 member organizations raising awareness about diabetes on the national level with the goal of improving diabetes prevention, detection, and care. The DAA is a Healthy People 2030 champion. The Healthy People 2030 Champion Program is a growing network of organizations partnering with ODPHP to improve health and well-being at the local, state, and tribal level. You can learn more about the Healthy People Champion Program by visiting the Healthy People 2030 website. Following these presentations, we will have a moderated Q&A with these speakers as well as a representative from the Healthy People 2030 Health Communication and Health Information Technology Workgroup, Daniel Hirsch. We encourage you to submit your questions into the Q&A feature located in the bottom of your screen throughout today's presentations, and we'll do our best to address as many of your questions as time allows. Now it's my pleasure to transition the webinar over to Rear Admiral Paul Reed to provide an overview of today's theme and the featured objectives. Paul?
Thank you, Debbie, and my thanks to everyone for joining today's webinar. I'm going to start today's discussion with a brief overview of the Healthy People 2030 objectives that we're going to be featuring. If I could have the next slide. The 3 Healthy People 2030 core objectives included in today's webinar are listed here on this slide and cover topics related to diabetes, regrettably an increasingly prevalent chronic disease that impacts tens of millions of Americans, and a related important aspect of high-quality patient care, good provider communication. And poorly controlled or untreated diabetes can lead to numerous complications, including amputations, vision loss, and kidney damage. But interventions to help people manage diabetes can help reduce the risk of most complications, and strategies to help people who don't already have diabetes eat healthier, get adequate physical activity, and lose weight can help prevent new cases. Effective and empathetic provider communication can support the prevention, diagnosis, treatment, and management of many diseases, including diabetes. Now, today's 3 featured objectives are managed by Healthy People 2030 work groups, which are comprised of federal subject matter experts who monitor these objectives throughout the decade, including the science behind them, relevant data, progress toward targets that have been set, and resources associated with each of the objectives. And these work groups help ensure Healthy People 2030 content is grounded in current evidence and available data. 2 of today's objectives are managed by the Diabetes Work Group. D06, increase the proportion of people with diabetes who get formal diabetes education, and D07, increase the proportion of adults with diabetes using insulin who monitor their blood sugar daily. And the 3rd objective discussed today is managed by the Health Communication and Health Information Work Group. HCHIT 02 looks to assess a decrease in the proportion of adults who report poor communication with their healthcare provider. All 3 objectives are Healthy People 2030 core objectives, as I mentioned, which means they will be tracked throughout the decade, and progress toward achieving their targets will be updated as data become available. As core objectives, they are measurable, have specific targets to be achieved by the end of the decade, reflect high-priority public health issues, and are associated with evidence-based interventions. They have valid, reliable, nationally representative data, including baseline data from no earlier than 2015. And the objectives as core objectives are expected to have at least 3 data points throughout the decade to assess any trends. Next slide, please. The first objective featured today, as I indicated, is focused on diabetes education. D06 tracks the proportion of people with diabetes who get formal diabetes education. Such education helps people gain the knowledge, skills, and abilities they need to manage their condition. This is a key factor in improving health outcomes in people with diabetes. The American Diabetes Association 2024 Standards of Care in Diabetes states 5 crucial points in a patient's experience with diabetes when the need for diabetes self-management education and support should be evaluated by a patient's healthcare provider and interprofessional team, with referrals made as necessary. And these 5 points are at the time of diagnosis, annually thereafter, when a care plan is not meeting treatment goals, when complicating factors influence self-management, such as other health conditions, physical limitations, emotional or social factors, or environmental conditions, such as a patient's living conditions, or when other transitions in life and opportunities for care occur. These standards also encourage diabetes self-management education and support to be culturally sensitive and responsive to individual preferences, needs, and values, be offered via telehealth when feasible, address barriers to access and pay, and consider individualized social determinants of health. The next slide, please. Now, the second diabetes objective featured today focuses on self-monitoring of blood glucose or blood sugar. Blood sugar control is critical in effectively managing diabetes and preventing diabetes-related complications, such as cardiovascular disease or damage to the retina, a preventable cause of vision loss and blindness in people who have diabetes. And D07 tracks the proportion of adults with diabetes using insulin who monitor their blood sugar daily. People with diabetes who monitor their blood sugar can track their response to treatment and find out if they're meeting their blood sugar targets. This can help with decisions about nutrition, physical activity, and medication use. And it can also help mitigate complications of insulin use. Self-management of diabetes requires tools like effective education and blood glucose monitoring devices so that individuals can best participate in their own care. As the American Diabetes Association 2024 Standards of Care in Diabetes indicate, people who are taking insulin and using blood glucose monitoring devices should be encouraged to check their blood glucose levels when appropriate based on their insulin therapy and unique circumstances. And this may include checking glucose levels when fasting, prior to meals and snacks, after meals, at bedtime, in the middle of the night, prior to, during, and after exercise, when hypoglycemia is suspected due to symptoms, after treating low blood glucose levels until they become normalized, when hyperglycemia is suspected, and prior to and while performing potentially risky tasks, including driving. The next slide. The Healthy People 2030 Diabetes Work Group has identified some valuable resources related to diabetes management on these next two slides. And the links on the slides will also be made available to all the attendees here in an email following this webinar. And if you could go through the next slide real quick. And then the next slide, please. Now, there's a demonstrated correlation between effective patient-provider communication and improved outcomes, including patient experiences of care. And the Health Communication and Health Information Technology Objective, HCHIT2, tracks the proportion of adults who report poor patient and provider communication. And this is a composite measure that combines data on adults reporting that their healthcare providers sometimes or never listened carefully, provided understandable explanations, showed respect for what they had to say, and spent enough time with them. Good communication is essential for high-quality care and can empower individuals in their self-management. Good provider communication can also establish a basis for patient education, in turn empowering patients with actionable information to support their informed decision-making and ability to better manage their own health concerns. The next slide. And the Healthy People 2030 Health Communication and Health Information Technology Work Group has also identified these resources related to health literacy and patient experience that can help support good provider communication. And these are listed on the slide. And again, links on the slide will also be made available to the attendees of this event in an email following our webinar. Now, I'm really looking forward to hearing the conversation today among our partners from the American Diabetes Association and the Association of Diabetes Care and Education Specialists. I think we will learn a lot about how these Healthy People 2030 objectives are put into action. First, however, I'm going to turn it over to NCHS to give us an update on the data associated with these three objectives. David, Commander Huang, I'll turn it over to you.
Great. Thank you so much for Admiral Reed. Next slide, please. I'm pleased to present data on three Healthy People 2030 objectives that set the stage for our discussion on diabetes management and health literacy. Following the same order as Rear Admiral Reed, I will start by discussing the objective that tracks the percentage of adults with diagnosed diabetes who receive formal diabetes education. I will then cover the percentage of adults with diagnosed diabetes using insulin who self-monitor blood glucose daily, and the percentage of adults who report having poor communication with their healthcare provider. All the data I will be sharing today are based on a subset of the full complement of information housed on the Healthy People 2030 website. And I encourage you to visit healthypeople.gov for even more data and resources about these and other related objectives. Comparisons made throughout today's presentation are statistically significant at the 0.05 level, unless otherwise noted. In addition, although I may use the terms percent and rate interchangeably for these objectives, note that the unit of measurement is a percent rather than a rate. Next slide, please. First, I will discuss adults with diagnosed diabetes who receive formal diabetes education. Next slide. The first two objectives that I will discuss today are tracked using data from the optional diabetes module of the Behavioral Risk Factor Surveillance System at CDC. The number of states that select the diabetes module varies every year, and rates for these objectives are a mean for the reporting states. For both measures, the data do not differentiate by type of diabetes diagnosed, and the data exclude women who only report gestational diabetes as well as persons who report pre or borderline diabetes. This first objective tracks the percentage of non-institutionalized adults aged 18 years and over with self-reported diagnosed diabetes who report ever taking a course or class in diabetes self-management. At baseline in 2017, 51.7% of adults with diagnosed diabetes had ever taken a course or class in diabetes self-management. The national target to be reached by the end of the decade is 55.2%. Next slide. This slide shows the percentage of adults with diagnosed diabetes who report ever taking a course or class in diabetes self-management from 2012 to 2022. Improvement was not observed over this tracking period, and since the Healthy People 2030 baseline, little or no detectable change has been observed. Note that data from the 2023 BRFSS have recently been released. However, due to time constraints, we were unable to run the estimates in time to include them in our presentation of this objective. We are actively working to incorporate these data into the Healthy People 2030 website as quickly as possible. Next slide. This slide shows diabetes education by sex, veteran status, and disability status in 2022. The differences observed by sex and veteran status were not statistically significant. Among disability status groups, adults without disabilities had the highest rate, 50.5%, and adults with disabilities had the lowest rate, 42.3%. Next slide, please. This slide shows diabetes education by race and ethnicity and educational attainment in 2022. Throughout this presentation, when discussing race and ethnicity, we'll look at Hispanic ethnicity along with race groups, which exclude persons of Hispanic origin. Among racial ethnic groups, Black adults had the highest rate, 53.4%, and the American Indian or Alaska Native adults had the lowest rate, 33.4%. Among educational attainment groups, adults aged 25 years and over with a 4-year college degree or more had the highest rate, 53.1%, and those with less than a high school education had the lowest rate, 37.6%. Next slide, please. Next, I will cover adults with diabetes using insulin who self-monitor blood glucose daily. Next slide. This objective tracks the percentage of non-institutionalized adults aged 18 years and over with self-reported diagnosed diabetes who use insulin and report performing self-monitoring of their blood glucose at least once daily. Self-monitoring includes times that their blood glucose was checked by themselves, by a family member, or by a friend, and excludes times that their blood glucose was checked by a health professional. At baseline in 2017, 89.0% of adults aged 18 years and over with diagnosed diabetes using insulin performed self-monitoring of blood glucose at least once daily. The national target to be reached by the end of the decade is 94.4%. Next slide. This slide shows the percentage of adults with diagnosed diabetes using insulin who perform self-monitoring of blood glucose at least once daily from 2017 to 2021, the last time the question was included in the diabetes module. Since baseline, little or no detectable change has been observed. Next slide. This slide shows self-monitoring of blood glucose at least once daily among adults with diagnosed diabetes using insulin by sex and race and ethnicity in 2021. Differences by sex were not statistically significant. Among racial ethnic groups, white adults had the highest rate, 90.1%, and American Indian or Alaska Native adults had the lowest rate, 81.1%. Next slide. This slide shows self-monitoring of blood glucose at least once daily among adults with diagnosed diabetes using insulin by health insurance status, obesity status, and household income in 2021. Among health insurance groups, adults aged 18 to 64 with health insurance had the highest rate, 88.7%, and adults with no health insurance had the lowest rate, 70.3%. Among income groups, adults living in households with incomes that are less than 100% of the poverty threshold had the highest rate, 96.2%, whereas adults living in households with incomes that are 400% or more of the poverty threshold had the lowest rate, 88.9%. Differences by obesity status were not statistically significant. Next slide. Next, I will cover adults reporting poor communication with their healthcare provider. Next slide. This objective tracks non-institutionalized adults aged 18 years and over who report that their doctors or other healthcare providers sometimes or never listened carefully to them, explained things so they could understand them, showed respect for what they had to say, or spent enough time with them in the last 12 months, using data from the Medical Expenditure Panel Survey, or MEPS. At baseline in 2017, 8.9% of adults aged 18 years and over reported poor provider communication. The national target to be achieved by the end of the decade is 8.0%. Slide. This slide shows adults reporting poor communication with their healthcare provider by race and ethnicity in 2021. 8.9% of adults aged 18 years and over reported poor provider communication, which is unchanged from the 2017 baseline. Among racial ethnic groups, Asian adults had the lowest rate, 6.6%, and adults of 2 or more races had the highest rate, 11.0%. Next slide, please. This slide shows adults reporting poor communication with their healthcare provider by family income in 2021. Among income groups, all adults with a family income less than 100% of the poverty threshold reported the highest rate, 16.0%, and adults with a family income more than 400% of the poverty threshold reported the lowest rate, 7.1%. Next slide. This slide shows adults reporting poor communication with their healthcare provider by age and disability status in 2021. Among age groups, adults aged 65 years and over had the lowest rate, 6.2%, and adults aged 18 to 44 years had the highest rate, 10.4%. Among disability status groups, adults without disabilities had the lowest rate, 7.9%, and those with disabilities had the highest rate, 11.9%. Next slide. I will end with some key takeaways. Next slide, please. The 3 objectives highlighted today all have seen little or no detectable change so far during the Healthy People 2030 tracking period. Disparities were observed for all 3 objectives, by disability status, race and ethnicity, and educational attainment for adults with diagnosed diabetes who report ever taking a course or class in diabetes self-management, by race and ethnicity, health insurance, and household income for adults with diagnosed diabetes using insulin who performed self-monitoring of blood glucose at least once daily, and by race and ethnicity, family income, age, and disability status for adults who report poor patient and provider communication. Next slide. Finally, I would like to thank and acknowledge the 2 work groups whose objectives were highlighted today, as well as the NCHS and ODPHP staff listed here for their contribution. I'll now turn it over to the next speaker, Paulina. Thank you.
Thank you, everyone, and good morning. My name is Paulina Duker, and I'm the Vice President of Practice and Learning at the Association of Diabetes Care and Education Specialists. It is my honor today to be part of this conversation about Healthy People 2030's diabetes objectives. These objectives may be statistics on a national agenda, but for us at ADCES, this is our lived experience. ADCES is all about these objectives. Next slide. So what I hope to do in the next 10 minutes or so is to talk about the work that we do at ADCES and how it aligns with the Healthy People 2030 objectives. I will talk about how I think the work we do at ADCES will contribute to and help inch towards the Healthy People 2030 targets. Next slide. So at ADCES, it is all about the team. 50 years ago, ADCES was formed as the American Association of Diabetes Educators. It was all about education for the person with diabetes and still is. Today, ADCES has over 11,000 members belonging to interdisciplinary groups, nurses, dietitians, pharmacists, physicians, psychologists, health educators, community health workers. ADCES broadly defines who diabetes care and education specialists are. It includes all levels of practice, starting from peer educators, community health workers, to our physician specialists. Our focus at the association is positioning all members as leaders in diabetes care, regardless of the level of care they practice at. ADCES supports an integrated model of care, a team-based approach to care, which assures quality, improves both patient and clinician experience, as well as outcomes for the person with diabetes. Enhancing the skills of our members, the diabetes care and education specialist, is another focus of ours at the association. And we do that through education, training, and resource development. Next slide. So the strategic approach we take is increasing access to diabetes care and education, what we might call formal education. And why this is important is because if you look at the other objectives of the Healthy People 2030, whether it's improving communications with the healthcare provider or taking insulin for patients who take insulin, monitoring their blood glucoses, all of this will happen for the person with diabetes if they have the opportunity to attend a formal education program. If you think about it, people with diabetes on their own, most of the day on any given day, have to make decisions that affects their diabetes. And they do that on their own, as I said. And so learning how to do this through a formal diabetes education program enables them to do this. Next slide. So how does ADCES operationalize these strategic approaches that we take to helping people with diabetes? So first, we want to talk about improving access to diabetes care and education. The goal is to unlock the door so more people with diabetes can access formal education. And the way we do that, one way we do that, is to create and provide evidence and disseminate the evidence to show the value of what diabetes education brings in the management of the person with diabetes. If we do that, if we show the value and more people understand how important diabetes education is and make sure that people with diabetes are getting diabetes education, that means we're going to have to advance the expertise of our diabetes care and education specialists, again, at all levels of care. So the next thing we focus on at the association is making sure that every person who takes care of people with diabetes has the right skills and education they need, or at least they can access the education they need through our ADCES resources. Right now, we have about 19,500 certified diabetes care and education specialists. This is not nearly enough for the 39 million people who have diabetes in the US. And so the way we skill professionals, our diabetes care and education specialists up is important so that for people with diabetes, wherever they are receiving care, whether it's with a certified professional or not, they will have the access to receive the best care and education. And that is why this is a big focus of ours, to advance the expertise of all levels of diabetes care and education practitioners across the board. And then lastly, as we know, the larger burdens of diabetes fall on our priority populations. An effort of ours at the Association of Diabetes Care and Education Specialists is to make sure that the priority populations are represented in our healthcare professional groups. We try to increase professional representation of these priority populations in our collaborative engagements with other organizations, and look for all kinds of opportunities to grow and diversify members of ADCES. Next slide. So one specific organizational infrastructure that I want to talk about is our diabetes education and accreditation programs. ADCES is one of 2 national organizations that are accredited by the Centers for Medicare and Medicaid Services to accredit education programs that seek reimbursement for diabetes education services. So to be able to bill for services in a formal education program, there are standards that a program must follow. If they set those standards and are able to demonstrate that they can follow the standards, either ADCES or ADA, which is the second national accrediting body, can provide accreditation so that they can bill for services. This is important because, again, this is one way of assuring that people with diabetes can access quality formal diabetes education programs. At ADCES, our accreditation program currently has 800 sites across the United States that are accredited. These accredited programs tend to have branches or multi-sites, and so there are additional 1,300 sites in addition to the primary 1,800 sites that offer formal diabetes. This is one way to operationalize formal diabetes education. There are national standards that have to be followed through these accreditation services that both ADA and ADCES provide. Programs can maintain the standards and get reimbursement and assure that these programs are sustainable and are available for people with diabetes. Next slide. Other resources that ADCES provides to assure quality diabetes education is, of course, the National Standards for Diabetes Self-Management Education and Support. This publication every 3 to 5 years, and we work in collaboration with our ADA partners to make sure that the standards for self-management education that are upheld in the formal education programs are current and are evidence-based. Other publications include the Diabetes Care and Education Curriculum, which supports for those who are establishing formal diabetes education. It's a guide for them on how to provide education and what to focus on in these programs for the people with diabetes that they take care of. Next slide. Other ways in which ADCES supports diabetes education is through partnerships and collaborations. Some of our current partners include the American Association of Nurse Practitioners. And in this partnership, we are really making sure that nurses have access to the library, the repository of education programs that we focus our time on so that the best diabetes education and resources are available for all practitioners. Similar relationship with the Academy of Nutrition and Dietetics. We work with each other and share resources for our mutual members so that, again, the people taking care of people with diabetes are practicing at the top of their licenses and with the best available knowledge. I mentioned earlier the national standards for self-management education. Every 3 to 5 years, when the time comes to review and revise these standards, we work with our partners at ADA to do this. One current partnership that ADCES is involved in is a partnership with Emory University Centers for Training and Technical Assistance. This is a CDC funding opportunity that has funded 77 national entities, including all 50 state departments of health and 27 national organizations. In this partnership over the next 5 years, we will support these funded entities with training and technical assistance for the funded entities and their local partners. So all of these funded entities are partnering with community-based organizations, with health systems, with rural health clinics, and so on, to increase access to diabetes services, both starting from prevention across the spectrum to diabetes complications prevention. And we make sure that they have all of the resources and the technical assistance they need to make sure that this is happening at the local level. 13 months through these partnerships, we have provided many webinars, office hours that have been attended by 1,300 plus grant recipients and their local partners. We've produced 100 plus resources, guidance documents, and all kinds of resources to support this work that we hope to continue to do over the next 4 additional years. Next slide. And then lastly, I want to talk about a great resource that we have at the Association of Diabetes Care and Education Specialists, which is our online webpage that talks about all things diabetes technology. Diabetes technology is just improving. Advances in diabetes technology are escalating so fast that our professionals have a hard time keeping up with them. So this website is our way of curating all of what's new in diabetes technology. It is open to professionals as well as people with diabetes. There are training programs on there regarding all things, as I said, diabetes technology related. And this is a great way for folks, both people with diabetes and professionals, to stay on top of all of the advances in diabetes technology. And with that, that gives you a flavor of some of the work we're doing at the association to enhance diabetes education for our professionals, but also to enhance access for people with diabetes to diabetes education services, and to make sure that when they do get in the door for diabetes self-management education services, they are getting the best from the professionals that they are working with. Thank you. And I will pass it on to the next speaker, Kevin.
Well, thanks very much, Paulina. I'm Kevin Peterson. I'm a family doctor and professor at the University of Minnesota and the vice president of the American Diabetes Association. As a member of the Diabetes Advocacy Alliance, the ADA is a champion of each of the Healthy People 2030 objectives. Let me review some of the major ways that the ADA will help mobilize our support in addressing these goals. The American Diabetes Association is the nation's leading nonprofit and voluntary health organization fighting to change the curve in this diabetes epidemic. For more than 80 years, the ADA has been driving discovery and research to treat and manage and prevent diabetes while relentlessly working for a cure. With over 560,000 volunteers, 12,000 healthcare professionals, and 350 staff members, the American Diabetes Association helps people with diabetes by developing programs through advocacy and through education designed to improve the quality of life. And we'll keep up that fight until we end diabetes once and for all. Next slide. We have a variety of programs, and so let me just review those. Our community programs sponsor screening and education and disease management programs that ensure leaders know about the social and the financial impact of diabetes and how to prevent it, with better access to care, affordable insulin, and other treatments. We promote inclusivity by combating discrimination at schools, in work, and in our hometowns across the country. We work to ensure that families, young and old, multi-generational, have access to the tools and the support they need to gain the confidence and the knowledge and the independence to live safe and healthy lives. Our successful programs such as Safe at School and the ADA Diabetes Camps are held across the United States to improve inclusion, education, empowerment, and collaboration. Our organizational health programs work with employers and health plans to sponsor health promotion and management plans in communities and at work and in schools. Our national advocacy and support programs advocate on behalf of millions of people living with diabetes at all levels of government. Working with professional societies and other advocacy organizations and public health agencies, the American Diabetes Association has been successful in driving the development, passage, and implementation of legislation and policy that ensures pricing transparency, affordable access to insulin and other medications, ensure better access to care, and support critical funding for diabetes research. Next slide. Our annually updated Standards of Care in Diabetes does an extensive review of the scientific literature every year, updating treatment recommendations to ensure that the latest evidence-based recommendations are highlighted and made accessible to healthcare providers. Similar to the ADCES program, the American Diabetes Association Education Recognition Program provides a framework for effective delivery of diabetes self-management education and support for diabetes education programs across the country. The program provides symposiums and educational tools and resources for certified diabetes educators and to help them maintain their national recognition. Our clinical programs provide screening and education and disease management programs delivered by trusted, community-based providers. Our nutritional support programs translate evidence-based diabetes nutritional standards into practical and accessible tools and resources for healthcare professionals. Next slide. In addition, the ADA is taking steps to scale this quality improvement activity to provide a strategy for national change in the delivery of diabetes care in the country's 85,000 primary care practices. By engaging the major primary care professional organizations in the Primary Care Council, the ADA is promoting the development of a single voice for primary care diabetes recommendations. That avoids confusion and conflict in the implementation of recommended care. As the primary care team grows, this allows more uniform messaging and responsibilities and a consensus across the primary care team. Finally, our new ADA Primary Care Diabetes Alliance currently engages 3,100 leading primary care diabetes practices from across the nation in a cascade of networks, promoting the rapid diffusion, dissemination, and implementation of the latest evidence-based standards. Working directly with practices to support changes in their diabetes care workflow, the ADA recognizes early adopters and thought leaders in care who adopt evidence-based standards in their care delivery. We're working to provide a model for change that will speed the diffusion of innovation to primary care practices across the country. Next slide. Through research, education, and advocacy, the American Diabetes Association is improving the lives of people with diabetes everywhere. But it will take all of us to end diabetes for good. Until then, we'll continue to fight. Thank you. I will turn it back
Thank you so
then
much, Kevin. I
to-
appreciate that.
Okay.
Thanks everyone for your wonderful presentations and all the information that was shared. I'd like for all of our presenters and our Healthy People topic area work group representative, Daniel, to switch on your cameras. We've already had quite a few questions coming in. Keep those coming. I'll keep an eye on the chat feature. So we'll start out with a question for Daniel, just focusing in on that health communication and health information technology objective. What would you like to share or add to the discussion related to the importance of patient and provider communication?
Sure. Thanks, Debbie. That's a good question. Really, I'd point back to the fundamentals of how we've updated the definitions of health literacy. I think they provide a really key manual for best practices on how to approach those interactions. And while they're generalized, you can apply those across several disciplines and practice areas. Specifically, I'd point to paying close attention to the role that organizations now have to play in health literacy and in provider communication. And some of the things that came out of that and the differences in the updates to that definition that would be really useful to employ on a daily basis in practice are emphasizing people's ability to use health information rather than just understand it, focusing on the ability to make well-informed decisions rather than appropriate ones. As practitioners, we often know what is going to produce the best outcomes, but that's usually in the context of, of practice. What does that mean in the context of people's lives? So ensuring that they're well informed on that decision-making process and have all the information available to make those well-informed decisions takes that from simply appropriate decision-making to best decisions and outcomes for the individual. The other thing, again, is to acknowledge that organizations have a responsibility to address health literacy, and in doing that, really when you're approaching those conversations and those interactions, to incorporate that public health perspective. It's no longer just the burden on the individual. It's a collective effort. We know so much about social determinants. We know about other things that factor into people's lives. Let's use that information and again, take this from appropriate to best outcomes.
Great. Thank you so much, Daniel. So the next question, I'm going to direct this to Kevin and Paulina, but Rear Admiral Reed, you may be able to add to this as well, so feel free to jump in. So the next question focuses then on diabetes care in rural areas and asking specifically about any resources, tools, or funding for rural communities, and what would you suggest in the approach for that? So Kevin and Paulina, could you cover that?
Sure. 90% of diabetes care is provided in primary care settings, and our rural areas have less access to providers, and they have far less access to certified diabetes education. I think it's a need that is clear. We most of our providers are in our diabetes education providers are in major cities and large areas, and it can be a 2-hour drive or more to get to an educator. I think it's a need that we can begin to address. We're taking a look at things like telehealth. I know that many of our, as we begin to drive a better electronic communication out to our rural environments, I think that there are new opportunities. But there's no excuse that we have why do we have such a disparity in access?
Thanks, Kevin. So let me just add that in looking at just some structures that are in place and how we try to address the access in rural areas question. One way ADCES is looking at that and implementing that is through our accreditation programs. So traditional formalized education programs tend to be in large city hospital-based programs. ADCES puts a special effort into looking to accredit programs that are in non-traditional areas, such as federally qualified health systems, health centers, as well as rural health clinics, and in pharmacy settings. And the idea is to go into these non-traditional areas out of hospital systems, take a little bit of the effort out of people having to travel to large centers to get their education, and make sure that this formal education is available to them closer to where they are, the same quality, hopefully, as these programs are supported to put in place accredited programs. One way we're doing that is through this grant funding that I talked about in the partnership with Emory University, where the focus is all about health equity and priority populations. So in the states, with the state's departments of health, we are focusing on what selected priority populations they choose in their states to work with. And that is where we do the work. And that means looking for new ways, going into the communities, doing community assessments, and sometimes coming up with novel ways of really addressing self-management education in those local areas.
Yeah, I might add to both of those remarks, which I totally agree with Kevin and Paulina on, that diabetes care education is indicative of a much bigger problem in terms of rural health and access in general to vital conditions of living, whether it be healthcare or many other things. I think the answer to several points that were just made is some sort of decentralization of the type of expertise and access to care that we know to be true in concentrated centers. And there are means to do that. Kevin alluded to telehealth. The good news there is that we're expanding bandwidth across the nation. Wi-Fi access and communications otherwise are going to reach places that they haven't reached before as a result of infrastructure development that we see happening. So those sorts of enabling tools like bandwidth, like expanded fiber optic capabilities, those will have a ripple effect into the way in which we distribute healthcare to remote places.
May
That's
I
great.
add
Thank you all.
that
Go ahead.
May I add that both ADA and ADC, as our sponsors of the Expanding Access to DSMT Act, which is a bill that has been introduced in Congress to really make things like telehealth a permanent access of diabetes self-management education. Telehealth became part of it during COVID, and we're going from year to year renewing. But this act is now pending to be approved to make telehealth a permanent part of it. And also part of this bill is also to remove the barriers such as the referral requirements to these diabetes self-management education programs, which may not necessarily be feasible for rural people in rural settings.
Great. Thank you for that, Paulina. David, the next question requires your statistical expertise. So we had a question related to the number of survey respondents, and if you have any advice or recommendations to states on how to mitigate small and poorly representative sample sizes in their data collection efforts.
Yes, absolutely. And these are issues that we certainly face at the national level as well. And, there's not a single solution to addressing, the issue of small sample sizes and declining response rates. There definitely are some approaches, though, that NCHS and others have taken to address these issues. One is actually to redesign a survey. So that's actually been recently done, for example, by the National Health Interview Survey out of NCHS and also the National Survey on Drug Use and Health out of SAMHSA. Redesigning the survey can reduce respondent burden by shortening the length of the questionnaire. It could also harmonize overlapping content with other federal health surveys, and just really also incorporate advances in survey methodology and measurement. In some cases, they could also maybe take a look at the mode of survey administration, so whether the survey is being done online or in person or via telephone. So that's kind of all on the data collection side, but then on the analysis side, some of the approaches could include combining years of data to produce more stable estimates, and then also potentially using techniques such as data linkage or small area estimation to produce estimates. And obviously there are pros and cons to these approaches, and those would need to be explored and communicated to stakeholders as appropriate. But just a couple of thoughts again on the data collection side as well as on the analysis side.
That's great. Thank you, David. So this one I'm going to direct to Paulina and David, but again, Riyad Moreed, feel free to chime in as well. We have a question related to prevention. So if you have any recommendations, resources, tools for the implementation of preventive measures as it relates to increasing community awareness to prevent diabetes, and is there a specific age group to target for prevention as well?
So I can start by talking briefly about, just as we do have formal diabetes self-management education programs, we also have diabetes prevention programs that are formalized. There's a way to get accredited to become a DPP, diabetes prevention program provider. In addition to that, we are constantly looking at the landscape and looking at where prevention programs can be most effective. And we have now family healthy weight programs that can be implemented for families through schools and other community centers. So there are formal diabetes prevention programs. We train lifestyle coaches that can offer support for people to prevent diabetes. And then in the school systems, in a family setting, we have family healthy weight programs that can also be implemented as part of this combination of services in diabetes prevention.
Maybe I'll just mention too that the American Diabetes Association has teamed up with the CDC, the Centers for Disease Control, to help promote and grow the diabetes prevention program, the DPP. That is a large effort that is primarily focused on 8 or 10 of the southeastern states from Georgia to Mississippi. And you'll see the further development then of state-based diabetes prevention programs.
Debbie, I'm sure you realize I can't help but step into that question. It's the essence of the work we do out of our office. I think the answer is not just specific to diabetes, frankly. Well, it is in many respects, but there are many answers or solutions, potential solutions that get at mitigating chronic disease broadly. And that can be obesity, that can be cardiovascular risk, et cetera, et cetera. And that largely has to do with much more macroscopic or upstream, if you will, factors that influence diabetes outcomes or diabetes prevalence. Nutrition, access to good, affordable nutrition is key. It's critical. And there's a slew of efforts that are taking place at the federal level and across the country that are pursuing just that. But it goes beyond nutrition. You know, we've come to refer to conditions like diabetes as diet-related disorders or diseases, but we know that it's much more complex than that, and there are many factors that play into it. Many of those factors are themselves implicating life circumstances, environmental conditions of living, access to good nutrition being one of those things. So I think it really falls into the category of what can we do to improve upon people's lives generally, their access to spaces for good physical activity, effective physical activity, for instance. And again, there are many steps being taken to look in that direction to mitigate the large burden of chronic disease, including diabetes.
So much for those responses. Unfortunately, we are getting close to the end of the hour. We'll have time for one more question, and then we'll close out. So, Paulina and Kevin, we did get quite a few questions on the role of community health workers, and perhaps any resources or information that you could share related to the role of community health workers and how they can be involved in this.
So let me share that in our formal diabetes education programs, we have well-defined places for community health workers. And to help implement that, we provide our practitioners with competency standards that we work with them and really hope that they can implement how to use community health workers, how to not use, but really operationalize community health worker skills in that setting. So we provide competency trainings. We also these competencies are evidence-based. So we go to our members and do research and get information from them on what are the necessary skills. And from those pilots, we come up with the competencies, but then it's the implementation phase. And that's part of the standards we help people realize in implementing them in their programs.
And I see that I'm noticing our time, but let me just say also that the ADA has strongly supported the involvement of CHWs in the extension of our primary care team. We have a certification program within that you can, if you go to the our ADA website, we have a variety of educational modules in diabetes specifically designed for CHWs, and are working with the National Certification Board as well as state-based boards in developing better criteria for certifying CHWs for all sorts of roles in supporting the diabetes care.
And we're
Great, thank you.
currently working with the Certification Board for Diabetes Care and Education Specialists to actually have a formal certification, national certification for community health workers.
Yes, we're working on those together.
Great. Thank you all so much for joining today's webinars and that rich discussion as well. That was great. For those of you interested in receiving continuing education credits, please be on the lookout for that email from cpd@confex.com, and a recording of today's webinar will be shared on health.gov in the coming weeks. So thank you all for your time, and we will see you at the next webinar.
Thank you.
Thank you.